Compression is exactly what it sounds like. It's just when something quickly compresses on the thoracic cavity and then possibly lets go. During compression injuries, this is when you can have a lot of organs that burst, obviously depending on the location of the compression. Okay, so we have blunt force trauma, compression, and penetrating trauma. So penetrating trauma or objects, obviously, these are things that go through the body. They may, they will always usually have an exit wound. There will always be an exit wound and an entrance wound. So your bullets, your knives, pieces of metal could be from either a car crash, explosion, glass, the same, could be just shredded glass from the window shield, steel rods. These are just some examples of what can cause a penetrating injury, but it's not everything. Obviously, it could be pretty much anything that can go into a body. Can be an impaled injury or penetrating injury. See, obviously, it can cause damage to internal organs as it's going into the body. It's going to physically injure those organs, and also any movement after it has entered the body. If it stays inside the body, it'll continue to cause harm with movement, possibly. So every time you have 2 or more ribs broken in 2 or more places, so that means that I have two or more ribs, so at least 2. So these 2 or more ribs broken, and each individual broken out of those 2 or more ribs have to also have at least 2 fractures per rib. So flail chest, that's what it's called. It's called flail chest when you have 2 or more ribs broken in 2 or more places. And what it does is that essentially it's see, how can I word this good? Essentially what this is a segment that has broken off from the rest of the chest. That's what a flail chest is. It's just a segment of the chest has kind of broken off from the rest of the chest, and now it's kind of doing its own thing, and that can actually cause damage to your patient. So if you guys do not know what a flail chest is, please write down the definition down here on the bottom. Flail chest occurs when blunt trauma creates a fracture of 2 or more ribs in 2 or more places. So I'm gonna give you guys about a minute. Go ahead and just write that down real quick, and we'll continue on. All right, should be enough time. So the issue with the flail chest is that every time all of your ribs they expand outward, so every time they contract and expand outwardly to make that negative pressure, because this section right here is broken, this would be your flail chest or flail segment, because that's broken off from the rest of the body. As your muscles are contracting outwardly and pulling these ribs outward, this little section will actually suck into the body because of that negative pressure, because negative pressure sucks in, right? That's why. So, and every time that happens, remember, these ribs, when they break, they don't break nice, smoothly, and even. They're gonna be jagged. So not only is this going to cause pain to your patient because of the bones rubbing against the tissue back and forth. But at the same time, it's going to cause even more damage because every time the chest expands outwardly so you can breathe in air to suck in air into your chest, this will also suck in with that. And then the opposite occurs. Every time that you release your air, relax your intercostal muscles to push that air out of your body, this right here will actually push outward as well. This is going to push outward because of the positive air that's pushing out from the body, also causing more damage and pain. So just in case you don't know that, we already have a definition down for flail segment. Well, that motion, that oppositional motion of the chest going outward with inspiration and the flail segment going inward, that opposite movement actually has a word, and it's called paradoxical motion. So if you don't know that, also write this down. Flail chest, this is flail chest, and as a result, this paradoxical motion is the movement of this segment moving backward from the rest of the chest. Okay, so go ahead and write that down real quick. Paradoxical motion is caused by flail chest. Any questions so far? Nope. Okay. Let's keep going. Okay, so some definitions, go ahead and write these down. If you want the actual definition from the textbook, flail chest, fracture of 2 or more ribs, consecutive ribs. That's the one thing I did leave this out. So they have to be consecutive, so back to back, next to each other, and that's what makes it a segment, a section of the ribs, because they're together. Ribs in 2 or more places. Paradoxical motion, movement of flail segment is opposite to movement of the remainder of the chest cavity. Again, I'll give you guys about a minute or two. Go ahead and write these down, and we'll keep going. All right. Patient assessment. So now that I went over the actual PowerPoint for flail chest and paradoxical motion, I'm going to share 2 videos with you guys regarding that. Share that. Here we go. Here's one of them. Oh, hold up. I got to reshare. New share. Share sound. There we go. Let me know if you guys can't hear this when I play it.
Welcome to this edition of the First Aid Show. Flail chest is a subject that's been added in the UK to First Aid at Work courses, and in this video we look at flail chest and its treatment. When a segment of the thoracic cage is separated from the rest of the chest, a condition known as flail chest exists. Flail chest is usually defined when 2 fractures exist on a rib, which produces a free segment which cannot contribute towards lung expansion. As the ribs are damaged, it can cause breathing to stop and require forced ventilations. When the patient breathes in, the flail section will fall, and when they breathe out, the flail section will be forced out. Where there is a flail chest, this is a very serious condition, and it's likely to be additional damage to the chest and lungs. Other conditions such as collapsed lung, known as pneumothorax, could exist. This is where the lung cannot inflate as there is damage and air has leaked into the chest cavity. In about 1/3 of cases where 3 or more ribs are fractured, a pneumothorax occurs. Common causes of flower chest are impact injuries, like those caused in car accidents by seatbelts. You'll see bruising, grazes, and often the chest will not rise and fall in a normal manner, although this may not be visible until they're laying flat. If conscious, they will complain of pain when they breathe in and out, and when you touch their chest. They'll also be breathing shallow because this is less painful. Treatment is to try and sit them up, and they may hold their chest, which could help them. This will give them the best chance of healthy gas exchange. This may not be possible if the person has spinal injury or they're in hypovolemic shock. Patients over 65 years old, fractures on both sides of the chest, or where the 3 or more ribs have been fractured, this condition can be very serious. If available, oxygen should be given to maintain their oxygen saturation levels. A patient with flower chest needs immediate medical attention.
All right, so was that. And now I'm going to show you guys different examples of flow chest. So here we go. So this one's right here. So they're always going to be different. Obviously, the anatomy of people are different, and the injury itself is going to be different. This patient, the flow chest, you can barely see it, but it's right here. The imaging isn't very well, but kind of see it a little bit. This one's also on this side. You can see it less because there's less bruising, but you can notice it right there if you pay attention. See how it goes in a little bit? The nipple, it's on the nipple side. There's a big difference. This one's nice and even. This one has an indentation with each breath. And this one's right here on this side. Looks like it's right underneath the collarbone. Goes a little. This one's obvious. This one's obviously it's a bigger section, so the flailed chest is gonna be a lot bigger. This just means that a lot more ribs were broken in 2 places along this path right here. So something must have been a seatbelt. Look, it's slanted. So that could have caused it possibly just by looking at the marks. Kind of same location. I just want you guys to watch this, so you guys can see that it's always going to be different, but the outcome is it's going to be paradoxical motion. It depends on the location and how many ribs are actually affected. You know, that will kind of dictate how it's going to present on the patient. Any questions? Nope. All right. Then I'll keep going. Go ahead and keep. Okay, we talked about that. So for your patient assessment, obviously the mechanism of injury matters. Like I said, that one patient where I thought just by looking at him that it was a seatbelt, kind of the same idea is, but it's you at the scene. So if I come up to the scene and my patient, I always use the steering wheel. My patient is collapsed over the steering wheel, and I see paradoxical motion or right below the collarbone section. I'm gonna assume that the paradoxical motion is because of flail chest, and the flail chest is caused because of the impact from the patient's thoracic cavity, being the chest, to that steering wheel. Of course, they're gonna have difficulty breathing. That's gonna be associated with hypoxia and a lot of pain. because of those ribs just rubbing against each other, back and forth, back and forth. So likely signs of shock and hypoxia are going to show. And now the reason for that is you have to kind of visualize what's going on inside the thoracic cavity. There's continuous lacerations of the tissue. So lacerations being a cut, right? Continuous cuts that are happening and tearing around the flail chest section. So what that can do is that it can actually cause fluid and blood and even possibly air, pockets of air, to occur and build up around the lungs themselves. If that occurs, now your lungs can collapse, so no air is going to come in. And if it progresses and continues, now that pressure can build up so much that it can actually affect your heart from contracting. And that's called obstructive shock. Shock because the heart is being obstructed. Excuse me. Chest wall muscles contractions. Okay, so now we're talking about an open chest injury. See, difficult to tell what is injured from entrance wound. Obviously, if it's an open wound injury, open chest injury, we're not sure exactly what's affected because it really depends on the projectile, what went inside the patient, and also did it come out, did it stay in the body, and we don't know of any movement after the patient got stabbed. Let's say if it's a stab injury, if they're moving around after being stabbed and the knife was impaled in the chest from the movement of the patient, that could cause further damage as well. So open wounds allow air into the chest, sets imbalance in air pressure and pressure. So we're talking about, pressure. And I kind of already covered that with the pressure being able to collapse that lung, which is the next bulletin down here. And then if it progresses, the air is going to start to build up inside the chest cavity and blood possibly. It could obstruct the heart from contracting. So it's the same, it's pretty much going to be the exact same issues, except that with this one you have an open chest wound, and with this one just a closed wound. But the same effects occur, same things occur. See, okay. Sucking chest wound, chest cavity is open to atmosphere. So a sucking chest wound is the same thing as an open chest wound, okay? And it's called a sucking chest wound because, again, every time your patient breathes in, air is going to go in through your mouth hole, and it's also going to go in through this hole in your chest, and it's going to make a sucking noise. So it's called a sucking chest wound because that negative pressure is sucking air into the chest from the hole. Chest cavity is open to atmosphere, may or may not be sucking sound, may be gasping for air. So obviously you want to maintain the patient's airway open so they can breathe. Seal the wound. That's the biggest thing you want to do is seal the wound with an occlusive dressing. Now, occlusive just means non-sticky. So a plastic bag, theoretically, that's occlusive. That could be used as an occlusive dressing. And the reason for that is we want for drainage to occur. So we want to allow for drainage to occur. An occlusive dressing allows for drainage of a sucking chest wound. At the same time, we don't really want anything to get stuck on there. So you want to give this patient oxygen, obviously, because if they have a sucking chest wound, there's a good chance that lung is collapsed and they're having a lot of difficulty breathing. So we want to pump as much oxygen to this patient as possible to make up for the lack of oxygen from that collapsed lung. Of course, we're going to care for shock. Being EMTs, we care for shock by keeping the patient warm, giving oxygen, high concentration, as said on the prior bulletin, and then just position of comfort for the patient. Whatever, and that's dictated based off the injury, the location, and patient comfort. Of course, if they have a sucking chest wound, we want to take them to the hospital as soon as possible. And then depending on how unstable your patient is, if they're stable or unstable, also how far away from the hospital you actually are, you may want to consider some ALS intercept. So what that means is that this bulletin right here, this bullet is pretending that you are in a BLS unit. So you're in a unit that only has 2 EMTs, no paramedics. So an ALS unit, it would be a unit that has a paramedic, or a paramedic and an EMT, but it has to have at least one paramedic. Okay, so let's see, occlusive dressing and flutter valve dressing. I'll show you a video on that if there's not a picture of a flutter valve dressing. Flutter valves are the dressings that are usually found in military settings. And I'll show you a picture. So involve taping dressing in place, leaving side corner. Let's see. Okay, so I'm just gonna go off of this one right here. So what you want to do is, if your patient has, let's say, a gunshot wound, right, in the thoracic cavity, let me find a, okay, so I'm gonna use this example right here too. Okay, so let's say that the bullet goes right in the middle, right in the middle of this whole little purple outline. And we're gonna pretend that this is just a really big occlusive dressing, all right? So this outline right here, that's outlining the flail segment, is our occlusive dressing. If the bullet hole is right here, and your patient is gonna set up Fowler or semi-Fowler for comfort, what we wanna do is we wanna tape pretty much around the entire occlusive dressing, and then somewhere in the bottom, we wanna leave a little opening for drainage, all right? And also it'll allow some air to escape at the same time. So we always want the open part of the occlusive dressing, the open part should be facing the ground. For that way, gravity helps with the leakage of the fluid, blood or whatever else may be leaking from the chest. So that occlusive dressing would be this right here. And so the whole idea is that that's the opening right there. So that would be facing down for gravity to help. Okay, that's the idea. The opening goes down towards the ground. So the idea here is that as your chest, these are your ribs, expand outward, they're going out, they expand outward to create that negative pressure. Air will no longer be sucked in from this hole because the negative pressure is sucking the plastic against the skin, creating a seal. At the same time, every time your chest relaxes and your ribs come inward to push that air out, air can escape through that little seal you left. So that's the idea behind the occlusive dressing that's taped on 3 sides. Okay, so now that I showed that, I can go ahead and share the video that I got for this as well. So the reason I chose this video is because it goes into a lot more detail than other videos that I found, and it reinforces some of the stuff that I already taught you guys. So let me know if you guys can't hear it, all right, when I play it.
Introducing the Hyphen Chest Seal from North American Rescue. The Hyphen Chest Seal is a self-adhesive occlusive dressing designed specifically for use in the management of casualties with penetrating chest wounds. The Hyphen utilizes the latest specialized adhesive technology in order to achieve and maintain a superior seal under the most adverse conditions. The Hyphen is supplied in a rugged, easy-to-open foil package that allows for quick and effective application in extreme environments. After action reviews from numerous healthcare professionals identified the recurrent requirement for an occlusive dressing that effectively adheres to a casualty's chest wall, the Hyphen Chest Seal was developed, tested, and validated through an extensive collaborative effort with these providers to achieve this requirement. The Hyphen Chest Seal meets the Committee on Tactical Combat Casualty Care's current guidelines for managing all open and/or sucking chest wounds. A penetrating chest wound creates an opening in the chest wall through which air may enter the chest cavity during the normal respiration cycle. Commonly referred to as a sucking chest wound, this injury results in a condition known as an open pneumothorax. An open pneumothorax occurs when there is a persistent communication between the internal thoracic cavity and the environment through a defect in the chest wall. Though this interferes with normal physiological ventilation, it should not create a tension pneumothorax, as the intrathoracic pressure and the atmospheric pressure equalize across the open wound. A tension pneumothorax can develop with a sucking chest wound, when the chest wall defect creates a one-way valve in which air can be drawn into the pleural space but cannot exit. Since the air cannot escape, the intrathoracic pressure increases, and a life-threatening tension pneumothorax can develop. The initial management of an open and/or sucking chest wound is to immediately apply an occlusive dressing to cover the defect and secure it in place. Traditionally, an occlusive dressing secured only on 3 sides has been used to seal penetrating chest wounds to help in preventing a tension pneumothorax from developing. Other types of chest dressings, some which contain pressure relief valves, are also in use, but there is little clinical evidence to show that any of these, or even the traditional 3-sided dressings, are superior to a completely occlusive dressing placed over the wound to cover the defect. Bleeding from the wound site, continued sweating, body hair, and other environmental contaminants may significantly limit the effectiveness of adhesive devices not designed to overcome these adverse conditions. The hyphen chest seal was designed with superior adhesion capabilities to conquer these challenges. This casualty has sustained a penetrating chest wound to his anterior chest with no exit wound. His lung has collapsed, and it is interfering with his ability to breathe. He requires the immediate application of a hyphen chest seal. These wounds are rapidly treated by applying a hyphen chest seal during expiration, placing the casualty in an upright position or in the recovery position, and monitoring his respirations for the possible development of a tension pneumothorax. Step 1. Wipe any dirt and/or fluid from skin with sterile gauze pad. Step 2. Grip large white flap and peel clear liner from dressing. Step 3. Place dressing on patient, adhesive side down, centered over the wound. Step 4. Peel and remove small white flap. Step 5. Firmly press dressing to skin, forming an effective seal. Position the casualty in either a sitting position or the lateral recumbent recovery position. Because air may still enter the chest cavity through the damaged lung tissue during the normal respiratory cycle, the attending medical provider continuously observes and monitors the casualty for signs of progressive breathing difficulty that may indicate the development of a tension pneumothorax. If the provider becomes concerned for a developing tension pneumothorax, they should follow their training and established protocols to treat this condition. Supporting tactical and pre-hospital healthcare professionals worldwide, and enhancing casualty survival by providing superior products designed specifically for austere environments is our mission and our privilege.
All right. Any questions about that at all?
Have you ever used one of those?
No, I never actually had to use one of them. But what I know about them is that there's been so much studies done on occlusive dressings, different kinds. There's like 3 different kinds right now, and like the video said, there's no evidence that actually shows that any one of these actually work or works better than the other. So all we're doing is just trying to seal it up because theoretically it makes sense. But yeah, so the short answer is no, and the long answer is all that I gave you. Not having used one. But that's what I know about them though. Okay, so let's keep going. All right, so a pneumothorax and a tension pneumothorax. All a pneumothorax is, it means that there's an air bubble somewhere inside the thoracic cavity that's not inside the lungs. But it's not growing. It's not growing, or it's not big enough to be life-threatening. A tension pneumothorax is a pneumothorax that continues to grow. Okay, the air bubble keeps on growing and growing and growing, and can become life-threatening. hemothorax and hemopneumothorax. Hemothorax just means that instead of air, pneumo means air, no air in the chest, pneumothorax, air in chest. This just means blood in chest. So instead of having an accumulation of air, we have a buildup of blood that is causing the pressure on the lungs to collapse and the heart to not compress or contract adequately. And then a hemopneumothorax just means that you have a combination of both blood and air. Cardiac tamponade means that there is fluid building up between the heart itself and that membrane that surrounds the heart. Remember, every single organ in your body has a skin, just like you do. The heart has a skin too. That skin is called the pericardial sac. Okay, so cardiac tamponade is when there's blood between that pericardial sac and the heart itself. And if blood continues to build up between the sac and the heart, it's the exact same thing as a tension pneumothorax. That pressure will not allow the heart to contract adequately because of all that pressure that's put upon it. Aortic injury, we kind of already talked about this. Like that's talking about the aortic abdominal aneurysm that can burst. Remember that big aorta that can burst in the chest and cause a lot of bleeding for your patient. So that's what that's talking about. So this was just what I talked about as far as pneumothorax versus tension pneumothorax. So I'm gonna give you guys like 2 minutes, 3 minutes to write these definitions down because they're super important, all right? So go ahead and take about 2 minutes and write those down. All right, so you know what? It's been about 30 minutes already. So let's take a 10-minute break. Let's take 12 minutes. I'm gonna give you 2 minutes to write this down and then 10 minutes for your break. And we'll meet up again at 8:05. All right, so let's see, tension pneumothorax. So air can enter the chest cavity through a puncture in the chest wall. We kind of talked about that already. That's an open chest wound. So this is just giving you a better visual of what we're talking about as far as air entering the chest cavity and causing a tension pneumothorax. So what happens with the open chest wound is that air just continues to come in here and come in here. And this right here represents your lung. And so we want the air obviously to be inside the lungs, which comes in through this pathway. And if air comes in through the outside, through your chest wall, then it's going to affect your respiratory system negatively, obviously, because it's going to collapse this lung. See pneumothorax. So again, this makes sense because if there is tension on the there's tension on your lung from this puncture wound, then your lung on the affected side is not going to be able to expand and contract adequately, during respiration. So because of that, because of the pressure, you're going to have absent lungs or diminished lung sounds, meaning that the patient is barely breathing or not breathing at all, pretty much. That's what that means. Hemothorax, we talked about this already. Now, if you want to get the actual definition, I'll give you guys a few seconds and just write these down. But we already talked about it. All right. Does anyone need more time? Nope. All right. So just some more visuals. So this right here represents a pneumothorax, meaning that there's only air that's causing the pressure to collapse this lung. This would be a hemothorax. The red represents blood, and that's causing the collapse and the pressure on the lung. And the very last one is a hemopneumothorax, meaning that blood, air in the thoracic cavity. It's a combination of both. So traumatic asphyxia is just when there's a lot of force that compresses down on the thoracic cavity so much that it's just going to cause you to asphyxiate pretty much rapidly. Sudden compression of chest forcing blood out of the organs and rupturing blood vessels. That would be when something completely crushes the chest, though. That's what it's talking about. The neck and face are going to be dark in color because of all that blood that's being backed up into the face. So that's why you get that change in color. Of course, if something compresses down on the chest, the thoracic cavity, that's going to cause pressure above and below that area. So once that compression occurs, as that compression is occurring, fluid is being pushed down onto your abdomen and up onto your head, which would cause the eyes to bulge, have distended veins, and the broken blood vessels in the face. So that's what's causing all that stuff to happen. Cardiac tamponade. I talked about cardiac tamponade already, but this is what's actually going on. If you actually want to write this down, like I said, cardiac tamponade is when that pericardial sac that surrounds the heart, whenever there's a fluid, most likely blood, obviously, blood between the pericardial sac itself and the outside of the heart. And that's going to create pressure on the heart and not allow it to contract adequately. So here's the definition of cardiac tamponade. I'm going to give you guys, of course, a few seconds to write this down because it's pretty important that you guys know the definition and what it actually is. And I think I have a video, so after this slide or the following slide, I'll show the YouTube video of that. Oh, before I forget, I'm gonna send the email out, but since you guys are in class right now, go ahead and send me which day you guys can come in for your skills. So we're gonna finish off the rest of your skills for the NREMT, and then go over some stuff that we couldn't go over, like bandaging and things like that. And I have 2 dates. So half the class is gonna come on one date, and the other half is gonna come on the second date. And we have, let's see, the dates are June 5th and June 6th. So it's a Friday and Saturday, and it'll be most likely we'll start around 9 o'clock, 9 a.m. 9, and then honestly, we're just gonna go as long as we have to go. So there is no cap. Obviously, no longer than about maybe 6-8 hours. But if we finish before then we finish before then. Okay?
What was the second date?
June 6th. So it's June 5th and 6th. You guys can come on one of those 2 dates. You guys just go ahead and just email me the date you can come in. That way I will have a roster for you guys and give you guys credit, obviously. All right, so that's what cardiac tamponade is. And this is what happens as a result. So blood's gonna back up into veins, obviously, usually as a result of penetrating trauma. Distended veins are going to occur. So the distension of the veins is because the heart can't receive blood anymore because of the pressure on it. So if the heart can't receive blood, then your veins are going to distend and get fat because blood is being backed up. That's going to show on your patient's neck. So they're going to have what's called jugular vein distensions, and the veins that return blood to the heart from your head are going to be distended and bulging out, and that's what that is. So let me go ahead and share that video too for cardiac tamponade, and there might be another one that I forgot to show. Here it is. Let me know if you guys can't hear the sound.
Hey everyone, welcome to Marvel Medicine. My name is Dr. Chaudhry. This lecture is about cardiac tamponade. This is a huge topic on the USMLE where they can ask you tons of questions. The first thing I want you to do is to visualize it. Imagine the heart, the ventricles, atria, and imagine the way it fills during diastole and contracts during systole, like a balloon. Now imagine the pericardial sac, a circular sac surrounding the heart. Try to get an understanding about the compliance of this sac. It's not very compliant at all. Well, what does that mean? It doesn't expand much, it's not stretchable. If you want to understand compliance better, check out the lecture here. Now that we have those images visualized, imagine a pericardial effusion. Imagine fluid surrounding the heart in this sac. If there's a lot of fluid and that sac isn't very compliant, the sac will fill, right? Now, if that sac is filled, do you think the ventricle has room to expand during diastole when it's filling? Nope. The amount of room it has to expand and fill reduces. So what do you think it does to the end diastolic volume? Goes down. So what happens to stroke volume? Goes down. You see how you can expand and extrapolate information? What do you think would happen to your blood pressure? Decrease. The other thing they love testing is the concept that the pressures inside the 4 chambers equalize. What does this mean? Imagine the heart with the fluid around it. Now imagine the ventricles and atria trying to fill up during diastole and expand. Notice that they really can't because the fluid is blocking them. Since that fluid is surrounding the heart all around, each chamber won't be filling differently. It will fill the same around, meaning the diastolic pressures will be the same. This is a huge giveaway. The discussion of tamponade also leads to the discussion of pulsus paradoxus. What you need to know is, in normal conditions with inspiration, your blood pressure will decrease, but not by much. Pulsus paradoxus is when the blood pressure decreases more than 10 millimeters mercury. Why does this happen? Visualize the heart. Now imagine inspiration. What does that do to interthoracic pressure? It decreases, right? Negative pressure acts like a suction or vacuum of sorts. With this negative pressure, venous return increases to the right side of the heart. If a patient has tamponade, and now more blood coming back to the right atrium, that means more blood going down to the right ventricle. Now, once all this blood gets there, the ventricle will want to expand, right? Well, on the lateral side, it can't expand because the fluid is blocking it. But look at the septal side. What happens is that the increased preload causes the septum to kind of curve in. When that happens, what do you think happens to the left ventricle's volume? It decreases. So what happens to stroke volume and cardiac output? Decreases. That's why you have the exaggerated drop in blood pressure.
Why aren't you the landlord? Yes, you. Why aren't you?
All right. So let's continue on with the lecture. I'm not going to cover more on this because I feel like we covered this plenty, aortic injuries. And then commotion cordis just means that there was an impact that affected the heart, and it hit the heart at the wrong time. Like it was during a vulnerable time that it actually threw the heart into a cardiac arrest. So ventricular fibrillation is one form of cardiac arrest, VFib. And for this one, again, I'm just gonna show a video. I found a pretty good video for this. It's a little bit on the long side, but I took a lot away from it, so I think you guys will too. So let me go ahead and share that one. I think it's this one, actually.
Welcome back to Catalyst University. My name is Kevin Tokoff. Please make sure to like this video and subscribe to my channel for future videos and notifications. In this video, we're going to discuss the mechanism of an acute and fatal cardiac event known as commotio cordis. Now, what is commotio cordis on a superficial level? Well, it occurs when you have a blunt force or blow to any area that's superficial to the heart. And usually when we think of an area superficial to the heart, we normally think of the sternum. And even though obviously when you hit that area, you're not directly hitting the heart, the impact energy that's hitting the area superficial to the heart, such as the sternum, that energy is translated to the heart, and we're going to talk about the mechanism of how that actually induces cardiac arrest and potentially death in over half the cases. Now, before we get into all the mechanisms of commotio cordis, let's do a brief review of the cardiac action potential. So here's the P wave. The P wave represents atrial depolarization, which in itself is associated with the contraction of the atria, okay, of the heart. The QRS complex represents ventricular depolarization, okay? And that's associated with the contraction of the ventricles. Now, understand also that the repolarization of the atria is also kind of hidden in here, but you can't see it over the QRS complex. Over here on the right, the T wave is ventricular repolarization, and any repolarization is associated with relaxation of that chamber. So when the ventricles undergo ventricular repolarization, they're in the phase of relaxing. Now, the key with cardiac muscle is that each one of these phases must occur in this order. Okay. Now they can occur faster, such as in the case of a faster heart rate, more frequently, but they have to occur in this order. In other words, you can't have a second ventricular depolarization before the ventricles have finished relaxing. Okay. That's what we see in tetanus in skeletal muscle. In skeletal muscle, you can have a depolarization before that muscle fiber has finished relaxing. That's how you actually get more powerful muscle contractions. But in the case of the heart, this cannot occur. So you cannot naturally have a ventricular depolarization until you have this ventricular relaxation or repolarization, and then the following atrial depolarization. It must occur in this order. If it does not occur in this order, let's say you were to have a second ventricular depolarization basically before this relaxation period is finished, then what would happen is you'd end up in ventricular fibrillation, and that's very, very bad because that tends to lead to cardiac arrest, in other words, a heart attack. Okay? So how does this relate to commotio cordis? Well, as I mentioned, it occurs because you have a blow to the area superficial to the heart. In other words, if you were to take a very hard punch, a kick, a knee, even something like a hockey puck or a baseball to the sternum, let's say, or anything that pretty much lies over the heart, so something that hits with a lot of energy, what is theorized to happen is you have activation of mechanosensitive ion channels. They're mechanosensitive, meaning they're sensitive to stretch and force, okay? And when you have that force hitting the sternum over the heart, that energy is translated to the heart itself, and that can activate these mechanosensitive ion channels, okay? And these are extra, that's the key word, meaning they're not supposed to activate, okay? But they can activate and they can cause increased excitation of particular muscle fibers, okay? Now, let's suppose we have an area of the heart that just happens to be in what we call the commotio cordis risk window. So it's a very narrow window of time, and it pretty much occurs during the first half of the T wave, okay? During ventricular repolarization, when the ventricles are supposed to be relaxed. Well, since you are not supposed to have a ventricular depolarization during this time, if for whatever reason you happen to get hit and you open these ion channels right when you're in the beginning of the T wave, you can actually artificially induce a second depolarization of that part of the ventricles, and this will occur before the repolarization is complete. And that's very bad because the ventricle does not get time to relax, and that disrupts the cardiac cycle, and you get ventricular fibrillation, which leads to cardiac arrest. And the reason that you really have this narrow risk window for commotio cordis is that if you were to open those ion channels during this time, you would induce a second ventricular depolarization prior to the relaxation of the same ventricles, okay? And that will cause ventricular fibrillation, cardiac arrest, and death. And typically what you see in somebody that gets commotio cordis is they will collapse because they're having a cardiac arrest, and really, even with defibrillation, an external defibrillator, this is fatal in over half the cases. It's fatal in about 60% of cases with a defibrillator. If you don't get the defibrillation in time, it's fatal in about 80% of cases, so it's extremely dangerous, okay? And one thing I want to mention is that there's a few
Oh, sorry. I thought I was still on. I was on mute. Sorry about that. But you guys got the idea, right? From the video of what commotio cordis is. All right. Okay, so let me play this one as well.
In an open pneumothorax, a penetrating injury to the chest wall allows air to enter the intrathoracic space. The loss of negative intrapleural pressure allows the lung to collapse, and ventilation of the lung is decreased. In addition, hemorrhage from the injury can accumulate in the thoracic cavity, resulting in hemothorax. Blood loss into one side of the thorax can be significant, as much as 1,500 milliliters, enough to result in the development of shock. In an open
See, so abdominal injuries, also the same as a chest injury, could be open or closed. Internal bleeding can be severe because of how big the abdominal section is. In the abdominal cavity, you have so much space to bleed out in that on average in most patients you might not even see or notice the extension or discoloration of the abdomen until about 2 or 3 liters of blood are lost. Now that's pretty significant. At that point, the patient has lost half their blood at least. So that's why it's so serious. You can lose a lot of blood inside of your abdomen. So as far as any abdominal injuries to hollow organs, they're gonna have a lot of contractions from the pain. So the hollow organs will contract as a result of the pain, and that's gonna cause as a result from the damage, and that's gonna cause your patient a lot of pain. Evisceration just means that something is sticking out of your stomach. So it could be intestines that are just kind of protruding out, they're hanging out. They may not actually be damaged themselves, but are hanging out from the stomach. So that would right there would be an evisceration in itself. Depending on where you get training and from who, would depend on how you would take care of an evisceration. But from what I gather from people that I've worked with and trained with and taught with, is that the concept and the idea behind the dressing of an evisceration is the same, and it's to keep it moist and sterile, and if possible, warm too. So I'm going to show you guys a video in a little bit of how to take care of an evisceration. And again, when you guys come see me in class, that's when we'll actually go over the hands-on stuff and even cover an evisceration and everything. Whatever we can do, we're going to do in class. See, patient assessment, pain initially mild, but rapidly becoming intolerable. Of course, and that's from the pressure behind the abdomen, behind the rest of the intestines. As that little part or section of your intestines is sticking out, there's going to be pressure behind it, and that's going to cause the pain to increase. Of course, it's going to have cramps. We talked about why, because the physical, what's actually physically happening to the intestines, the pressure on it is going to cause it to cramp up, nausea, weakness, and thirst. See, stay alert for vomiting. Place patient on back with legs flexed at knees. The reason behind this is that if the patient's knees are flexed up, it reduces the tension on the abdominal wall, the abdomen muscles, and it's gonna reduce the pain a little bit for your patient. Obviously, give them oxygen and care for shock. See, give nothing to the patient by mouth. Obviously, they have an abdominal issue, so don't give them anything by mouth. Monitor vital signs. Let me see, is there anything that's really, really important here? Additional steps for opening abdominal injuries. Oh, for open abdominal injuries, I'm sorry. Of course, we're always gonna control the bleeding for any situation, and it's going to be direct pressure. That's our go-to, direct pressure. And if it's a normal dressing, we're going to try to maintain pressure for at least 10 minutes before we leave it in place. If it's a dressing that has hemostatic agent in it, then we have to apply pressure for at least 3 minutes and then wrap it in place. So do not touch or replace eviscerated organs. Obviously, when we are taking care of an evisceration, we don't want to apply more pressure than needed. The whole idea behind a dressing for an evisceration is that we want to keep those organs moist so they don't have any more damage, and we also want to keep them sealed from further contamination and warm as well. Additional steps for open abdominal injuries. Okay, talked about that. Additional steps. Stabilize with bulky dressing, bandages in place. Always keeping in mind to not apply more pressure than needed. Like I said, leave patient's leg in position found to avoid muscular movements. And then that's gonna be it for today, guys. I'm gonna show this video and then the evisceration video. And then our test for this chapter we'll actually do when we meet next time, which is gonna be on Thursday night. Because today's Tuesday, Wednesday, Thursday, yeah. So I'm gonna play this, share new.
The liver is the largest solid organ in the body and is highly vulnerable to both blunt and penetrating injury. The liver is the largest solid organ in the body and is highly vulnerable to both blunt and penetrating injury. Due to its significant vascular supply, profound hemorrhage and death from hemorrhagic shock is possible from blunt and penetrating trauma. Injuries can range from simple to severe and include simple subcapsular hematomas to expanding hematomas to lacerations to fractures to complete avulsion from the hepatic artery.
Okay. I'm going to share the last video, and then we'll be done after that. If you guys have any questions, go ahead and stay behind after the video. If not, you guys can log out as soon as the video is done. Abdominal evisceration.
Hi, I'm Anthony and I'm a paramedic, and today I'm going to demonstrate to you how to treat an evisceration. First thing we need to do, seat safety, universal precautions. Ensure you're wearing your gloves. Remove the clothing from the injured side and inspect the wound. Raise the patient's legs for an abdominal evisceration and ensure he's slightly tilted forward. This takes any pressure off the abdomen region. Remove a sterile dressing from its packaging and place some sterile water onto the dressing. This will keep the intestines moist. When you're happy that the dressing is sterile and moist, apply pressure onto the intestines. Do not try to push the intestines back into the cavity. Roll the bandage around using the small of the back. Ensure that the dressing is sealed above and below the site of injury. This will ensure less risk of infection. Once the dressing is in place, we can further reduce the risk of infection by placing tin foil or cling film directly over the dressing. For the purpose of this demonstration, we will use cling film. Once the cling film is in place, begin using the small back. Once the cling film is wrapped around the evisceration, if you have saline available to you, you can have the saline inserted into the dressing, turn on the saline, and this will keep the dressing moist at all times.
All right, guys, that's going to be it for me today. Like I said, next class, we're going to have the test for this chapter and the following chapter. And we are going over musculoskeletal trauma next time. So it's chapter 28, all right? And I still have to look into my Brady. I know that there's been a few issues. I'm actually gonna log on there tonight after class and see what's going on with that and open up some of those tests and assignments.
What time did you say we're gonna see each other on June 5th?
I'm gonna shoot for 9 a.m. 9 a.m.
Okay.
Yeah. If nobody has anything else, have a good night.
Good night.
Night. Hello.